Why does metformin cause vitamin B12 deficiency? Well, this is a very strange drug side effect, and USMLE loves this. And before I start explaining, I will ask two questions: that where is vitamin B12 absorbed in the gastrointestinal tract, and what does that absorption require? Because once you understand this physiology, this metformin connection will make perfect sense. B12 is absorbed in the terminal ileum, and this absorption is not a passive process. Rather, it's a highly selective process, and it requires the presence of intrinsic factor which is produced from gastric parietal cells. And this intrinsic factor, vitamin B12 complex, then binds to a receptor on the terminal ileal luminal membrane called cubilin receptor, which is then subsequently internalized in the enterocytes. And here's what USMLE wants you to know, that this cubilin receptor is actually calcium dependent, meaning that this receptor requires the presence of calcium for to grab onto this vitamin B12 intrinsic factor complex into the enterocytes. And here's the interesting part, and here's how metformin plays important role in depleting vitamin B12 stores. That metformin actually alters the availability of calcium at the brush border of terminal ileum, and therefore when calcium is not available, the receptor is not able to grab onto this intrinsic factor vitamin B12 complex. And even though you are taking vitamin B12 in the diet and your stomach is producing adequate levels of intrinsic factor, but still the final step of the absorption is not taking place in terminal ileum, and therefore the vitamin B12 starts depleting from the body. But you should remember that it takes years of metformin use before you develop vitamin B12 deficiency. And therefore USMLE gives a scenario about a diabetic patient taking metformin for 5 to 10 years, and then on the peripheral smear you will see macrocytes and peripheral neuropathy. And here's the trap, that students, when see neuropathy in a diabetic patient, they think immediately of diabetic neuropathy. So you should always check the MCV first, and if the neuropathy pattern is atypical of diabetes, then you should always check vitamin B12 factors first, because that might be metformin induced vitamin B12 deficiency causing elevated MCV and macrocytosis and atypical neuropathy. And here's the interesting part, that metformin induced vitamin B12 deficiency and subsequent findings of macrocytosis and peripheral neuropathy of atypical type, these are reversible findings, whereas diabetic neuropathy is not reversible.